Hello, my name's Nick Screaton. I'm speaking to you about imaging in Covid-19. The role of imaging in this condition is both to identify imaging features which are suggestive of the disease, as well as to rule out alternative causes of the patient's symptoms. Imaging can also help assess disease severity, evaluate complications of Covid-19, and mainly by assessing severity can be of prognostic value. The imaging modalities we have available to us include the chest X-ray and CT, which I'll talk about briefly towards the end of my talk. For an imaging test to be utilised, it should have both diagnostic and therapeutic impact. We may have an imaging modality which is highly sensitive but may be impractical and unsafe for staff and patients. And as we'll mention towards the end, I think that is largely the case for CT. It should be limited to patients where it is going to have an impact. The chest X-ray, typically in COVID, is going to show increased lung density. That density may be subtle increase in density, which is called ground glass opacity, when we can still see interstitial markings or vascular markings separate from the areas of increased lung density. The X-ray you're looking at there shows normal vessels streaming out into normal lung. We can clearly see the vascular markings. In contrast, in this X-ray, you can see that the vascular markings are poorly defined. We can't see any air bronchograms, but there's just diffusely ill-defined vascular markings on the right in particular. So that's diffuse ground glass opacity. As density gets greater, the lung becomes consolidative. Here we can see no vascular markings, but you can see diffusely increased density with some air bronchograms. Remember, the changes on imaging can be subtle, they may be absent in early disease, and consequently it may be very helpful to compare with previous imaging to help us identify subtle abnormalities. The distribution of abnormalities on X-ray are typically bilateral, peripheral in the majority, and lower zone in the majority. X-ray is going to help us assess the severity of disease, and if we sort of dichotomize at the 50% of the lung opacified level, we can divide Covid-19 related disease into mild, less than 50%, moderate, around 50%, and severe, more than 50% of the lung opacified. I'm going to show you some examples now. So in these cases, both have less than 50% of the lung opacified. On the left, you can see diffuse ground glass opacity, lack of clarity of the vascular markings, but no air bronchograms. On the right, you see patchy areas of consolidation in the lower zones, and ground glass opacity, which has a peripheral lower zone predominance. Around about half of the lung involved in these cases, there's patchy consolidation peripherally on the left-hand image, and it's got a lower zone predominance on the right-hand image. Both also have diffuse ground glass opacity. So that's moderate severity disease. These patients have severe COVID-related disease with more than 50% of the lung involved. It's got a mid and lower zone predominance on the left, a bit more diffuse on the right-hand image. This patient clearly has severe COVID-related disease. They're intubated and have central lines in place and extensive bilateral patchy areas of consolidation. In that case, it doesn't have a peripheral predominance. Remember, a normal chest X-ray does not exclude COVID-19. Chest X-ray is insensitive in mild and early disease. Up to 30% of hospitalized patients with COVID-19 pneumonia can have a normal chest X-ray. Around 40% of those patients with a normal chest X-ray may have abnormality on the more sensitive test, which is CT. And the imaging findings in COVID-19 can evolve over time. Same patient, as you saw previously, normal chest X-ray evolves to subtle ground glass opacity, losing the vascular markings, some areas of consolidation, and more diffuse ground glass opacity and consolidation by day 4. Typically, the peak of chest X-ray abnormality will be around about 10 to 12 days. Ground glass opacity will often progress to consolidation. We mentioned that the chest X-ray is insensitive in some cases. It's also non-specific in that similar findings may be seen in other infective processes, including viral pneumonia and pneumocystis, as well as other inflammatory conditions such as hypersensitivity pneumonitis, smoking-related lung disease, organizing and eosinophilic pneumonia, as well as edema and diffuse pulmonary hemorrhage. However, in the appropriate clinical context, the imaging findings are highly suggestive of the condition, and you know their context. CT features in COVID-19 consist of ground glass opacity and consolidation with that peripheral and lower zone predominance that we've seen on chest X-ray. These features would be highly atypical for COVID-19, so more focal, lobar consolidation, cavitation, and so-called tree and bud opacity are uncommon in COVID-19 and much more suggestive of an alternative disease process. So that would be a classical pattern for COVID-19. Peripheral, basal, ground glass opacity and consolidation. We can be almost 100% confident in the right context that that patient will have COVID-19. This would be defined as probable COVID-19 pattern, which is peripheral in places around bronchovascular bundles and more central in others, for example, in that right upper zone image. Around about 80% of patients with that pattern in the appropriate context will have COVID-19 infection. This would be indeterminate for COVID. It doesn't rule it in, it doesn't rule it out. So there's ground glass opacity, it's peripheral, but it's pretty mild. And around about 60% of people with that sort of pattern, indeterminate pattern, will have COVID. What is the role of CT? To summarize, really, it is not of additional value in patients who have typical clinical presentations. And that summary has been supported by each of those professional bodies, particularly in the UK, United States, and Europe, which do not support the routine use of CT, preferring to use it as a problem-solving tool when imaging findings and clinical features are disproportionate, non-concordant, if you like. Remember that in patients with COVID-19, up to 30% of hospitalized patients will have pulmonary emboli. So when there's disproportionate symptoms, and a CT is required, we should consider doing CT pulmonary arteriography. In terms of pathways, this is the UK pathway from the British Society of Thoracic Imaging and NHSE. It suggests that we should be performing chest X-ray in the majority of patients who require hospitalisation. CT should be limited to those individuals who are seriously ill, have low oxygen saturations below 94%, or a NEWS score of greater than 3. In that context, when the chest X-ray has been normal or non-diagnostic, a CT scan can help dichotomize those patients into those who have probable or definite COVID patterns and those who are likely to have another disease process. So to briefly summarise, chest X-ray is the first line imaging test. A normal chest X-ray does not exclude COVID. Imaging features are non-specific, but in the right context, highly suggestive of the condition. They tend to peak at 12 days after the development of symptoms and consist of peripheral, lower zone predominant ground glass opacity and consolidation. CT is not a screening tool, but may be a very useful problem-solving tool. Thank you.